I'm the CEO at the Patient-Centered Primary Care Collaborative, and I'd like to thank you for joining us today for our national briefing. I'm going to be just offering a couple of remarks up front, some housekeeping, and then I'm going to be introducing our guest today that highlight the work of WellSpan Health, which is a community-owned, not-for-profit health system and leader in population health. They have been doing fantastic work to align healthcare services with the patient-centered medical home. And both Amy Gibson, the COO at the PCPCC, and myself have had a chance to see them in action and meet with not only their care teams, but also the patients from those care teams. So we're delighted today to have Lori Brown, Chris Echterling, Karen Jones, and Ann Kunkel here to present to us on this topic. Before we jump into that, just a few quick announcements. For those of you on our webinar today who are not already receiving our monthly PCMH PCPCC briefing, please go to our website and get signed up. You'll see we've got some announcements there. We'd like to thank folks who joined us earlier this month for the first 2014 Western Regional Conference, together with our partners Health Teamworks and the Colorado Academy of Family Physicians. We had over 350 healthcare stakeholders from all across the United States join us, and the presentation slides are now available. In that regard, we're looking to have lots of you join us for our next annual meeting, which is this fall, and the conference website is now open November 12th through the 14th in Washington, D.C. Our conference is titled The Patient-Centered Primary Care at the Heart of Value and Quality, and our early bird rate ends September 26th. So please head to our website and get signed up. We'd love to have you join us. We launched our map earlier this month at the Denver conference. We're calling our map the New Primary Care Innovation and Patient-Centered Medical Home Map. We identify over 500 active programs and initiatives happening all over the United States. And you'll see if you go to that map, we've got WellSpan and the terrific work that Aligning Forces for Quality have been doing in the state of Pennsylvania. So you'll be able to hear our speakers, but you can also check out the map and some additional material about their work. And then finally to the webinar. Just a few specific housekeeping rules. As you probably know, we use our webinar software to ask questions or to provide comments. Please do submit your questions in writing using that drop-down question box on the screen. During the last 15 minutes after the presentations have ended, I'm going to open it up, or Amy actually is going to open it up for questions and answers from the audience and from our speakers. And then also for those of you who are multitasking, watching USA versus Germany, and you want to go back and revisit these presentations, you'll note that they are recorded and posted to our website. We will not be stopping the webinar for action on the World Cup, but we will have these available within about the next 24 hours. So we understand everyone has their priorities. Go Team USA. And with that, we have the lengthier bios of all four of our speakers on our website. So I'm not going to read them to you, but I do just want to point out a couple of things about the folks who are joining us on our webinar. Lori Brown is the Clinical Director for Quality and Innovation for WellSpan Medical Group, and she is the Nurse plus Masters of Business Administration person. So she is the Clinical Director, as I mentioned, of Quality and Innovation, and she works with the Medical Director and the Quality team to develop and implement their comprehensive quality improvement program. Next, Dr. Chris Echterling is the Medical Director of the Bridges to Health and the Healthy York Network at WellSpan Health. He's also now the Associate Medical Director for Quality and Innovation at WellSpan Medical Group, which is about 750 providers in more than 64 practices. He's been involved in leading WellSpan Super Utilizer pilot, as I've mentioned, he's a medical director of Bridges to Health, which is an ambulatory ICU program for high utilizers. He's also been the champion for behavioral health integration. Next is Dr. Karen Jones. She is the Chief Medical Officer for the WellSpan Medical Group. As I mentioned, 750 primary care and specialty care providers across South Central Pennsylvania and in Northern Maryland. She serves as the physician champion to the RWJ-funded Aligning Forces for Quality project in South Central Pennsylvania, which is just the coolest project. It brings together providers, consumers, payers to improve the quality of care and engage patients in the community. And as I've mentioned, I got to meet these patients myself, and their enthusiasm is absolutely infectious. I might say it maybe was my favorite meeting I ever went to, but I don't want to get in trouble with my other friends. And finally, we've got Ann Kunkel, who is the nurse and the director of case management for WellSpan Health, where she's been since 1989. She joined as a behavioral health nurse, and then she did medical oncology. She assumed the role of utilization management nurse, and then was one of the first nurses at York Hospital responsible for developing care coordination and case management services. And she has transitioned to the director of case management for WellSpan Health. So with that, I'm going to turn it over to the WellSpan team. Thank them so much for joining us, and all of the folks on the line who are with us today to learn about this very special team doing very special work in Southeast Pennsylvania.
Thank you, Marcy. This is Dr. Karen Jones. I would be remiss if I didn't tell everyone on the phone that we also have another person in the room with us, and that's the project director for Aligning Forces for Quality in South Central PA, and her name is Chris Amy. And really, without this special funding, we wouldn't have had the catalyst to get us started. So it's been a true catalyst for us, and we'll tell you a little bit more about it as we go through. So thank you all for having us on the call today. I wanted to let you know that we are a community-owned, not-for-profit organization, and what's interesting about us is, especially compared to when we start talking to our peer groups around our region and area, is we really don't think of ourselves as a hospital-based organization. We think of ourselves as a system of community-based, and really that's really driven home by the fact that more of our income comes not from the hospital, from more of our ambulatory and practices. So it's been in our culture to really think about how we coordinate care across our whole continuum, as opposed to just when someone is in the hospital. You can see how many employed physicians, primary and specialty physicians that we have. We also have many private practice physicians that are aligned with us, volunteers. We're an academic center, and that's the concept that I really want you to take away from this, is that we think of ourselves across the whole continuum. This slide shows how we organized our thoughts when we took our own employees and mapped our own total healthcare spend to our number of patients. And just like any other slides that you probably see along these lines, we found that 10% of our own employees consumed over 2/3 of the spend. And this was a real eye-opener for us to see that, yes, this really applies to us. This isn't just a theoretical number that's out there. And we realized that we need to work to try to keep people to the right of this curve. So those who are high utilizers or have severe injuries, we want to move them back towards the middle with our chronic illness. And for those who are well or think they're well, we'd like to keep them there. And we realized that we need a strong care management approach across our system to be able to do that. One of the ways that we've organized this is through our patient-centered medical home and patient-centered medical neighborhood. And the reason we have our patients, our family in the center here, is because that's where we like to revolve our care around them. And we think of this in a three-dimensional view, where the medical home supports the patient and family, And then the medical neighborhood supports the medical home to be able to support the patients and families. And you can see how we've defined our medical home with primary care being pediatrics, family medicine, internal medicine, and then the neighborhood really is all of our specialty, but more than that, it's our pharmacy, behavioral health, it's our ED, home health care. But we know that as a system, we cannot do it ourselves. We cannot cure this or make this all better unless we engage our community. And we are so fortunate to have the Area Agency on Aging engaged with us, where they're actually going into the homes with people who are discharged, and they communicate back to our patient-centered medical homes and our care coordination teams. We are Aligning Forces for Quality has allowed us to have the platform to be able to gather other hospitals, EDs, nursing homes around the table to talk about how we do this as a community. And it's still a work in progress. Next. This slide has helped us go from changing our mental model and how providers think. And it's been something that we've been talking about with all the providers over the past year. I wouldn't say that we're all there because, as you know, it's a work in progress. But this concept where we move from my patient to our patient, from my own clinical preferences to WellSpan's clinical standards and preferences, where I'm really oriented only to my practice site and what happens there, as opposed to thinking about how my practice fits into the neighborhood, thinking about my plan for the patient as opposed to the patient's shared care plan. And Dr. Echterling will tell you a little bit more about that later in the presentation, where in the electronic health record, I'm not just documenting my thoughts, but I'm sharing my thoughts not only with colleagues, but our patients now can see all of their notes, whether it's inpatient, whether it's a hospital admission, the discharge, or the office notes. And that I'm coordinating my patient's care to our team works with others in the neighborhood to coordinate care. Going from the thinking of RVUs, of the number of services I provide, to the number of people we serve. I would say we have a foot in each canoe on that, and it's hard to navigate, but that's what we're in the midst of. And that we make decisions not only based on quality and revenue, but how is it now that we think about quality and charges or cost. So that's what's been one of these. I'm kind of giving you some background grounding principles for us that we've used as we move forward. We realized that we need building blocks in order to make all this happen, and we started off with focusing on our patient-centered medical homes. We achieved recognition for that, and all of our practices are recognized. Half of them now are in the 2014 level 3, and we're just about to apply for the rest of them. I'm sorry, 2011, not 14. But the way we think about that is it's like when I got my degree in medical school, that's necessary but not sufficient. And we need to put the patient piece into our patient-centered medical home. So we developed our Patient Partners Program, and that has really been a huge piece of what Aligning Forces for Quality has helped bring to us. They help coordinate that for us, and each of our practices have invited patients to become part of their improvement teams, where the patients actually come into the practice each month with the improvement team in the practice, and they look at data and look at how to improve and also give suggestions about making a better patient experience. We then worked on our care coordination team, and that is more detail to come on that, but I will tell you it's where we have realigned the inpatient focus of our nurse case managers and social workers and have connected them more across the continuum, so they're aligned now with our patient-centered medical homes and back to a health coach that's in the practice. So those three, the nurse case manager, social worker, and health coach, make a triad team. We know that we have patients who have super extraordinary needs, and that's our Bridges to Health program that Dr. Echterling will talk to you more about. And then our behavioral health integration piece is something we've just begun, where we have a pilot in 2 practices, and we're getting ready to expand into 5 others where we have a behaviorist embedded in the practice. And we look at all of these as what makes up our home, our medical home, and movement to the neighborhood, not just recognition. by a certifying body. Aligning Forces for Quality was a grant that we received in 2007. In 2010, we began our first collaborative, and then we started with primary care. And I'm pleased to tell you that we're in our 5th year. We've just begun our 5th year of the collaborative. Each year, we've added practices to it. All of our WellSpan Medical Group practices have been through it. We have independent practices in it, and they continue. And this year, we just last month added specialty practices so that we're focusing on the neighborhood and the patient's journey through the neighborhood, and how is it that we close the loop so that there's they feel that we're connected and communicating. And that's a huge undertaking for anyone who knows what we're trying to do. This consists of monthly meetings, whether they're webinars or in-person dinner meetings. And at that time, that's when we were so fortunate to have Marcy and Amy come on 2 different years to help our practices, to cheer them on and to let them know what else is going on nationally.
This is Chris Eckerling now, just making a switch. So as we were doing all this work in the patient-centered medical home arena, our idea of the neighborhood obviously meant that we needed to tie in with the work of our hospitals. Most of our case management up until recently had occurred in our hospitals. And so at the same time, Ann Kunkel and her team were leading a redesign of our concept of case management and care management across our entire system. And it came together really perfectly with the work and the development of our patient-centered medical homes. So the way we think about care management now across our whole system is we really think about it in sort of 2 situations, but interconnected. One is individual case management of individuals with either temporary extraordinary utilization, perhaps after a surgery, or chronic utilization based on their chronic medical problems. But increasingly, we're also thinking about a critical part of care management being population management. And we're developing, like many other health systems, that capability from relatively small components of our population to what we envision for all the population we care for. And that's sort of making sure we take care of all the patients that we're responsible for, but also helping those involved in individual case management be able to recognize patients at risk, or what we call rising risk, who we suspect that based on our knowledge of situations will be in a crisis situation perhaps in the future, so that we, our patient-centered medical homes, can intervene sooner and hopefully change the trajectory of their care to a more positive one. Next slide. Mm-hmm. So just to share with you, Karen talked a little bit about this idea of the triad of the care coordination teams. And this is really critical, again, to connecting our hospitals and our patient-centered medical homes, to transforming how we think about our patient-centered medical homes and what they're capable of. So we, like many other hospitals, the hospitals in our system, had case managers. We had RN case managers already in a dyad with a social work case manager. And probably like most of the hospitals we've run into, they were aligned to physical units. So that dyad of an RN or a social worker were perhaps the one for trauma surgical, or they're the one for labor and delivery, or for oncology. And that made sense because they got to know the nurses, they worked well with them, they do a fantastic job whenever a patient came in there. But as you know, if a patient came in one time for oncology, the next time for trauma surgical, and the next time to a med-surg floor, it would be another team, a separate team each time, trying to do a great job for the patient, with really no sense of continuity for the patient. So what Ann and her team envisioned, which was quite an undertaking and has been an undertaking, and frequently along the way has been met with skepticism by many concerned, but we were just sharing that we just received accolades from our own case management staff of thanking us for having the vision for doing this, is that we reorganized our case management so that now the case managers in the hospital are aligned to outpatient patient-centered medical homes. They still live mostly in the hospital. They still move around the hospital, but they are now Yorktown Family Medicine's care coordination team or East York's care coordination team. So now when a patient of East York comes in one time for congestive heart failure, the next time because they got hit by a car on trauma surgical, it'll be the same RN case manager, the same social worker that sees them in both locations. So you can imagine how this changes the dynamics, because now the conversation is not like, oh, you're having transportation problems, so they won't ever address that with you. It can be like, I remember last time I gave you that application for mass transit. How did you do on that? So there's an automatic understanding and trust built, particularly with our chronic patients. In addition to that, the two hospital-based parts of our care coordination triad team every day communicate with the third part of the triad, which is a health coach in our patient-centered medical homes. Those health coaches are either LPNs or medical assistants, and every day they have a virtual huddle where they talk on the phone about patients that were admitted from that patient-centered medical home the night before and patients that are being discharged back, so that the team can sort of say, you know, I was working on housing for this patient, I didn't get it totally done, they're going to need follow-up at their visit within 7 days at your practice on this application, please make sure you talk to them. Or the outpatient team can say to the inpatient team, you know, this patient got admitted last night, I really want you to know this about them, you know, they're illiterate, or they're caring for their demented mom, and this is really important to know about them. And so that conversation occurs about the transitions of care, but it also, the health coach in the patient-centered medical home has the opportunity of tapping into the knowledge of the RN case manager and social work case manager about other difficult cases she's dealing with in the patient-centered medical home that aren't being admitted, but she can tap into those resources that normally would not have been available to her in the patient-centered medical home. So we've held the team accountable for daily huddles. Actually, this slide shows 70%, but I think we've been pushing 80%. Yeah, and that's part of our overall strategy. Also, we're doing, like many of you I'm sure are doing, we expect our health coaches and our practices to reach out to patients within 48 hours, do a medication reconciliation, make sure the VNA actually showed up, and then our practices are expected to see our medical and behavioral health discharges within 7 days. And so you can see there our accomplishment of that recently. Next slide. So just to give you an example, I mean, these are just two cases of many, many what we call bright spots. If you notice, our logo is sort of a rising sun, so we call our great things that we like to share with one another bright spots. And so these are just two of many, many examples. So East Berlin Family Medicine, one of our patient-centered medical homes, had a patient discharged from the hospital by the hospitalist team. They wanted the patient to go to a rehab facility, but the patient insisted on going home. Over the weekend, the patient had multiple falls. Emergency medical services was out putting the patient back in bed. They came in Monday morning to East Berlin Family Medicine. Obviously, the family realized at that point that they had made a mistake. They weren't able to care for this individual at home. In our old world, the patient-centered medical home, with all its advances, would have been recognized that this was an issue, but be completely incapable of doing a direct placement into a skilled nursing facility from the outpatient facility. We would have simply sent the patient to the emergency room. They would either got care there from the care management team or maybe got admitted, and then the care management team would have done a great job at placement. In this situation, because the care coordination team already knew the patient, they were able to hold them at the outpatient practice, and we were able to place the patient in the skilled nursing facility directly from the outpatient facility without another hospital admission. Yorktown Family Medicine, just another case similar in that a mother and daughter came in at their wit's end and was struggling to care for the mother at home with her problems. And with the help of the inpatient RN case manager and social worker, the outpatient health coach in that triad was able to make really critical referrals, including the area agency on aging, to bring resources into the home, and we believe avoided admission. Next slide. So Karen talked briefly about our shared care plan. So this is really a transition shift from I just need to convince the patient to understand my plan for them and get engaged to I need to understand what the patient's goals are and how to align my goals for their health along with their goals, and to make their goals through their shared care plan available to all of those that are caring for them in the medical neighborhood. So again, we're just beginning this, but our health coaches are all beginning shared care plans on all the chronic patients that they're engaging, particularly those that may be being admitted to the hospital and aren't reaching their health goals. And this is a templated checklist for them to sort of ask the patient, how do you get to appointments? How do you prefer your information? Do you have any trouble reading? Who's the other important people in your life? Who do you want us to share information with? If you wanted the care team at the hospital or rehab to know something important about you, what would you want them to know? And it can be things like, I really hate getting my blood taken. I'm scared of needles, to I can't read, to I want my husband to know everything about me, to I don't want my husband to know anything about me. And so these are going to a shared care plan, and then we put that, we're trying to increasingly make that highly visible to the ED, the inpatient team, and the outpatient team so that we can honor the patient's wishes and engage them as a member of the team. Next slide. So when we made this transition, I alluded to the fact that we didn't have all our care management staff jumping up and down saying, I'd love to go all over the hospital and not be at the unit that I've known the nurses forever from. So there was a lot of challenges in morale and concept, and then bringing the outpatient world in. And then when our health coaches started calling patients, they were dealing with issues like patients that they're calling on the hospital follow-up call and the patient's sharing that they're suicidal and didn't quite know how to deal with those issues. So we brought all of our care coordination team triads together in another collaborative, separate from our patient-centered medical home collaborative. And they still continue after a year to meet every month for at least 2 hours, where we bring in external resources such as maybe behavioral health, talking, or updates on motivational interviewing, to sharing their bright spots with one another. And this brings the health coach physically together with the 2 other members of their team that are usually in the hospital. We have 2 counties that are represented, and this has been absolutely transformational in keeping people engaged, getting them over the hump of resistance, and moving us forward in a very, very positive way. Next slide. So just some results. This is all great stuff, but if it doesn't result in results, as you well know in your health system, programs don't last very long. So this is our initial data looking at what we do is when our care coordination team gets engaged with a patient, we ask them to associate themselves in our electronic health record with the patient, so that then we can go back and look at outcomes pre and post association with the care coordination team in the practice. And these are just some initial data that show both encounters for our care coordination teams 6 months before involvement with the care coordination team and 6 months after, both in terms of inpatient and ED encounters, and then the number in boxes is charges associated with those encounters. And you can see we've had our care coordination teams be able to have a positive effect on patients. In the bottom right then is, the upper left is 6 months involvement, pre and post, and the bottom is those patients that have been involved with the care coordination team for 12 months. And you can see, again, decrease in utilization. Next slide, please. And then overall, our work of patient-centered medical homes, we'd be remiss that overall, with all the patients involved, we've been seeing decreased readmissions over 3 time periods as we track that overall comers to the patient-centered medical home. And the bottom right is the readmission rate pre and post involvement with our care coordination teams. Next slide. This is just to show you quickly, I'm sure like you do, we've developed our own internal dashboard for quality. And this is our example of our quality dashboard. This is what we call the front page of our quality dashboard, which are the strategic initiatives for our system at any given time. Now, all 30 of our patient-centered medical homes, every month, for usually 2 hours, have every staff member, front office, back, secretaries, practice manager, physicians, nurse practitioners, sit down, and part of their standard approach to their all-staff, all-provider meeting is to look at this dashboard, to see how has it changed from the month before, to determine what they're going to work on, and to see the results of their action. So literally, this again has been transformative in guiding our teams to data and pulling them constantly back to looking at quality data about the population they serve. Next slide. And then we can sort this different ways. Some of the practices love to go on and sort by practice and see how many stars they get. A star, it represents that they've met the quality goal. A star in a blue background meant they met the quality goal and they exceed top 10% in the country. So we have many of our practices are constantly comparing themselves to others, which is positive. I should note that this data, when shown at the practice level, is provider specific. So in my practice, it's showing me and my partners up there in front of my entire staff, comparing our congestive heart failure or advanced directives. And that unblinded nature has led to the accountability that we think is key to our transformation. Next slide. This is jumbled, but it just gives you a sense. We went the whole way back to 2011. We tracked several of our key components. This is actually our process component for diabetes. And we wanted to see, when we step way back, is all this making a difference or not? And you can see the general trend. The dark line in the center is the composite for the entire medical group, all 30 practices rolled up together. And we're pretty confident that all this hard work is paying off and that we're continually seeing improvement in the quality of those we care for that we would not see without these efforts.
This is Karen again. It's great to look at data, and we look at numbers and such, but the thing that we always want to bring back to our practices is what our CEO likes to call the so what factor. So what does this really mean in terms of people? And so when we look back from 2010 to 2014, You can see how many more people have received a pneumococcal immunization, and then we know from studies for about every 382 people who get a pneumococcal immunization, we prevent one episode of sepsis or meningitis. So we feel pretty confident that over this period of time in our counties in south central Pennsylvania that we've prevented at least 18 cases of invasive pneumococcal disease. The next picture, when I talk about remembering that we're not just talking about numbers and data, these are people. And so I've mentioned to you about our Patient Partners program, that 2 patients per practice are on the quality improvement team. They have training and empowerment that's been provided through our Aligning Forces for Quality. They have monthly patient partner meetings, and they join the practice leadership team to review the data and give their perspective. So I just wanted you to see the pictures of this, because when you go around and you see them sitting at the table and they say, this is my team and our team and we're working together, you know that they're very engaged. One of the patient partners, for example, said, I know that you're trying to work on improving your eye exam rates, and they said, if you want to improve it, why don't you put your data in the waiting room so that all the patients can see it? And so the practice did, and then another practice said, well, gee, if you're going to do that with eye exam data, we want to improve our pneumococcal immunization rate. So this picture shows by provider in the waiting room, actually in the vestibule when patients walk in, what each care team's pneumococcal immunization rate is. So that whole transparency piece is critical, and that idea came from one of our patient partners. Then we wanted to know, well, has it made a difference in our patient experience? And what I would say is, as you all know, patient experience numbers are really hard to move, and I'm happy to say for some of these things that are these are patients that are medical home questions, that we've made directional improvement, not as much as I would love to see, but it's going in the right direction. On the next slide, we take our numbers of percentage of patients who have an A1C greater than 9, and based on data from studies, we know that if we improve that percentage of A1C control by a certain amount, that we can actually prevent deaths, heart attacks, amputations. And this is what we ask our practices to focus on, not only the numbers, but how many episodes of blindness or amputation did they prevent. And that's on the left. On the right is when we stand back and look at what are potentially avoidable hospitalizations based, we scoped this to diabetes at this point. And so this includes long-term complications, including amputations as well as short-term complications. And in this time period, we reduced our potentially avoidable hospitalizations by 8%. Then we said, well, what about all of our inpatient visits? And the year before, we were at 65 per 1,000, and it decreased some. But then we wondered, well, how does that compare nationally? And it's harder to get the data on that, but we do have at least by Medicare, and you can see the line at the top, the rate for Medicare. And for commercial is at 35, and we were in between there, and we have some data to show that the whole state of North Carolina has the rate at 50. So we have some improvement to do, but I think that's key. The point that Chris and I and the rest of the team here want to drive home is we can start off with vision and ideas, but we have to measure. Next slide. Mm-hmm. When we've looked at our rates that Chris showed you about our ED visits and hospitalizations, that was viewed through the lens that we have, and that was only through the hospitals that we own, that we have that data from. So then we said, well, what if we look at a population, our own employees, and look at their total cost of care? And for those employees that are in part of our patients in our medical home, we saw a decrease in their total cost of care over this period of time. And that's in the face of national rates going up at 4% per year. So we're going to be updating that data and see how we're going on that. So I would say this is a trend. We're not claiming victory yet, but I wanted you to know that we're looking at it.
So this is Chris Eckerlin again, just to talk to you briefly about our super utilizer program. We call it Bridges to Health. It's, again, with any population, when you start to manage the population, even when you empower your patient-centered medical homes with all these tools that we've just described to you, there are certain patients that fall outside at least their immediate capabilities that require an intensity, at least to sort of sit down and learn more about or visit them in the homes or try to piece things together that even with all these capabilities, the patient-centered medical homes have trouble with. And so that's our Bridges to Health program. It's based on work of Jeff Brenner out of Camden, New Jersey, which many of you are familiar with his hotspotting work. And our program is what we call an ambulatory ICU. It's basically a transitional primary care program where we assume primary care responsibility for the patient for a period of time, apply intensive efforts, and then hopefully have a change in new linkages and new empowerment of the patient, new support for them, and then turn them back over to their patient-centered medical home. We have really a multidisciplinary model of behavioralists, nutritionists, social workers, all kinds of people involved in this program. Next slide. So what we do is we use that data on the population to identify the individuals that would qualify for this intervention. Then we approach the patient-centered medical home and we sort of say, hey, Dr. Jones, what do you think about Mr. Smith being a part of our program? If Dr. Jones agrees, then we go to the practice and Dr. Jones introduces us to Mr. Smith, asks Mr. Smith if he's willing to be involved. If he is, then we assume the care for Mr. Smith for a period of time and then hopefully have good results and turn him back over to Dr. Jones. We do home visits. We consider them critical to our understanding of the patient, their family, and their true adherence to both nutritional and other issues at home, including medication. The next slide will show you the results, sort of in a similar format as we had for the care coordination teams before and after involvement in our Bridges to Health program. Interestingly, everyone's attention is usually drawn to the ED visits. The way we record data in our system is that an ED visit that results in an admission or an observation never gets recorded as such as an outcome, as an ED visit is recorded as either an observation or an admission. So what we've been able to do is through building really good trusting relationships with our emergency departments, we're able to intervene and allow them to feel comfortable sending a patient home that they would have otherwise insisted be admitted because we're able to give them background on the patient and we're able to assure them that the patient can either see us later that day, we'll see them that night, or they'll see us tomorrow morning. And with that reassurance and understanding, the ED doc is willing to discharge them. And so we're left with some ED visits that actually would have resulted in admission. So overall, a total dramatic increase in charges that are avoided, but actually early on at least our program and other sister programs have shown some increase in ED utilization for some of these patients. Next slide. And then the whole question comes up, this is a really question of our alumni. You can see the numbers are much smaller, 15. These are people that have been alumni for 3 months at least. Because obviously an intervention like a super utilizer program is great and it can decrease utilization, but unless it's going to be deployed forever, the real question is what happens to people after they leave your program. So we were very satisfied that this was our first look at 15 patients who have left our program, have returned to the patient-centered medical home, and have shown actually decreased utilization even more after returning to the patient-centered medical home than certainly before joining Bridges, during Bridges, or even during Bridges. So, next slide. This is key. You can tell we're sort of collaborative nuts here. So our program for Bridges to Health quickly found through Jeff Brenner and other people similar programs through really, in many ways, considered competitor health systems nearby in Harrisburg, Lancaster, up in Allentown, and then down in Crozier near Philly. And we all got very excited about meeting each other, started sharing our war stories, and actually formed another collaborative for just super utilizer programs under Allied Forces for Quality with funding from the Highmark Foundation, which is an insurance company foundation. And we literally now meet every month, either by webinar or in person. We have our teams share their successes, their failures, and we're actually in the midst of combining our data. It's allowed us to learn from one another, not repeat each other's mistakes. It's given us a voice on the state level with Department of Health and Department of Public Welfare that we've never would have had as individual programs. and we're actually completing now a white paper that will hopefully be published nationally soon. So. One last thing is, so we've also started to deploy pharmacy resources into our population health approach. We have 2 population health pharmacists that are now deployed with our practices. It's an evolving process. Originally, we hoped to engage them as a resource for every practice, and we realized that quickly our 30 primary care practices would overwhelm the 2 of them. So we deployed them to some early wins, a proton pump inhibitor project where we knew with our own employees and their family if we could just switch people to generics, not even get them off of maybe proton pumps that they don't even need to be on, that we could save $900,000 within a year. So those pharmacists helped create action lists for the practices. We didn't just push lists out to practices like we all get from insurance companies all the time, but we actually went out, met with the physician leader there, got their buy-in, and we met with all the staff, all the providers and staff, explained why we were doing this, provided them resources to be able to hand to patients, and our practices have gone at it and had already dramatic cost savings for both our system, but also for patients themselves because of co-pays. And we're going to be working towards other projects like certain cholesterol-lowering meds and biologics shortly.
So our challenge is the next steps. We know that we have an inpatient case management tool that we would like to optimize to help identify our rising risk and readmission folks, and we think that there's opportunity there that we need to maximize. We want to continue transforming our primary care practices. We have not had pediatrics involved, and they will be getting a health coach and a care coordination team this year. We have begun on our inpatient units having structured interdisciplinary bedside rounding, of which case management, if they're oriented to a patient-centered medical home and not oriented to a unit, it makes it challenging to figure out how they fit into that structured interdisciplinary bedside rounding. So we're beginning work and trying to crack that nut. And then linking, if we have a patient with a shared care plan and a care coordination team, but then they go to oncology, how is it that we make sure that the cancer care navigator really knows where to find that shared care plan and then to link back with the care coordination team. So that's our work before us now. And then on the last slide comes to sustainability. And we took a stab and actually did this with Laurie, where we said, okay, do we have any direct revenue and cost avoidance? Because of the care coordination teams with the health coaches, with the care coordination E&M coding, we've been able to capitalize on that. We did not even go into our transitional care manager program, which are nurse case manager, CRNPs that go into the home of patients who've been discharged from the hospital, particularly after something like a heart failure admission, and try to optimize medications. And so we have that program. And then we have the cost avoidance of the potentially avoidable hospitalizations that I mentioned to you before when we reduced our diabetes avoidable hospitalizations from 19 to 17.5. The avoidance of the pneumococcal disease, our bright spots, hospitalizations, and bridges to health. And then the employee cost savings that we talked about. So it's a beginning. We're excited about it. We feel like we're making a difference. And we would like to open it up now to any questions, comments, thoughts.
Well, this is Amy here at the PCPCC. Thanks so much for an incredible presentation. And we've got an incredible list of questions that have come in. So I'm going to get right to it, and hopefully we can get through quite a few of these before our time runs out today. So maybe, Anne, this is a question for you. We've gotten a lot of questions about the specific roles of the members of your care coordination team. So can you maybe give a little more description about who constitutes a team, what are their various roles and responsibilities, and what kind of training do you have to provide everyone, knowing that some of these roles are new, especially around the health coaching?
Yeah, so the case managers and social workers we require our case managers to have a minimum of 5 years of clinical experience prior to accepting a case manager role, simply because of that critical thinking and critical assessment aspects to the role. That's a requirement. In terms of our social workers, they're a mix of BSW and master's prepared social workers with regards to their background. All of our staff, we have a significant amount of longevity in our case management function overall. In fact, the average tenure is about 17 years. So it was more a matter of getting the cultural buy-in in terms of that. So their background was pretty significant. Chris mentioned the collaborative, and we have a lot of training that we've needed to pay attention to. So, for example, the case managers and social workers were really not oriented to go into a provider's office as in any other way than being a patient in a provider's office. And so we were very purposeful in having an introduction process, a frameworking with every practice from the leadership team as to what the importance of this team was, what the roles were, and delineating that. And then through our curriculum, we put together the curriculum through our community health educators. And I think that's another important perspective in terms of this. We really wanted the staff to be thinking of the patient interaction from the standpoint of a lay person. And so having the community educators, health educators, setting that curriculum was really important. So training around motivational interviewing, with actually recording in simulation lab with patient actors, so the process of education was not just a didactic presentation, here you go, but really a validation process in terms of how these skills are being transformed into their interactions and practice. And Lori, do you want to add anything for the health coach?
The only other thing that the health coach had special training in how to manage transition of care calls. So we had a consultant come in and do the teaching initially, but we have a very structured format and documentation process for managing when the patients are discharged out of the hospital and make that first phone call, so that we are discussing all the key components. So they've had very specific training around the transition to care. In terms of the qualifications for a health coach, that is an LPN or a highly functional physician office assistant, a POCA clinical assistant that has a medical assistant degree that has advanced to what we have a clinical ladder to level 2, and that way they've had at least a year experience and have been functioning in a patient-centered medical home. So they've had that experience. So that's our qualifications. But the most important thing with our health coaches is that they are very patient-centric and very engaged with patients and have a passion really for their role.
Great. Are you using any particular evidence-based model for the transitions program?
So our Area Agency on Aging program uses the Coleman model. And actually, I would say in terms of our health coach function with that, it's a combination of models. Karen mentioned the nurse practitioner visit that we have, and that follows somewhat the Mary Naylor model from the University of Penn, where the care coordination team can deploy the nurse practitioner for patients who've been identified as high risk for readmission. And we have a electronic record algorithm tool that helps us to identify a patient as being readmission risk. And then when they do their follow-up phone call, if there's patients from that phone call and the nature of the conversation, if they identify them as having vulnerabilities or things not going so well, they can deploy the nurse practitioner at that point in time. In addition, they may set up the nurse practitioner visit program if for some reason we couldn't get the patient. Our goal is to have patients seen by their primary care physician within 7 days. You saw our results around 87% for completed visits. But if there would be a delay in 2 or 3 days, the nurse practitioner gets deployed to go see, to go out and visit patients.
Fantastic. So in regards to some transitions, you know, a lot of people on the call might be thinking, well, this might be a little easier for all of you because you've got such an integrated system there at WellSpan. How challenging is it for you, or have you developed some key strategies for transitioning patients among services that are not part of WellSpan?
Mm-hmm. That remains a challenge, although I do believe, and Karen spoke to this, that the community effort around the work of aligning forces for quality has raised awareness to certain standards. So, for example, I would tell you, if you looked at Dartmouth Atlas data on transitions of care and looked at central Pennsylvania, you would see that we have a positive significant variance in this area for follow-up appointments within the state of Pennsylvania. While I think our work is attributable to that, I do think that there's a broader community awareness around that standard expectation in terms of that.
This is Karen. The other thing I would add is that when Ann was having to reconfigure the way the nurse case managers and social workers in the hospital were oriented, they have patients that are admitted from non-WellSpan medical homes.
Yes.
And so they ended up orienting those nurse case managers and social workers to those independent practices as well.
Yeah, so actually thanks, Karen, because that is an important piece to mention. So we talk about our care coordination teams, and to keep them organized, we have Chris mentioned the Yorktown Care Coordination Team, which is known as Care Coordination Team 8. Okay, and so in Care Coordination Team 8, that hospital case manager and social worker has our medical group practice, Yorktown, but then they have a grouping of non-medical group physicians where we do traditional hospital discharge planning for those patients. The benefit to the independent practitioners and the patients, more importantly the patients that are in the hospital, is we have gained continuity with that patient, because every time a patient from an independent practice comes into the hospital, they too have the same case manager and social worker assigned to them. And probably that was the most challenging part of the change in terms of the hospital work with this. Having said that, it also has been the most eye-opening and somewhat gratifying, not somewhat gratifying, because when a patient comes in, we know they have a cat, and we know that that cat is really important to them, and that the fact that their cat is home alone, it doesn't have someone caring for them, is an important issue. We know patients' cares and their wishes and desires over time, and that has been, I think, really that has created the platform for us to get beyond, and we continue to get beyond, because in no way would I want to say we've made the full shift in culture, but it has really given us that platform for moving our culture away from a fragmented approach to a longitudinal relationship.
The other thing we've done, and this is also in part with the A4Q Nursing Council, is we've developed relationships with nursing homes and with the hospitals on our fringe counties, whereby we are getting their discharge summaries and we're getting their reports, and we've developed relationships. It's not perfect yet, but we have made a lot of inroads so that our coaches and care teams see the same information we get from our own hospital.
So with that, our health coaches, for example, we do a transition of care phone call, as well as we look for a follow-up appointment when a patient is moving from nursing home back into the community. So we've taken that same standard that we apply at the inpatient level and have advanced it out to further into the continuum.
Excellent. Thank you. So we've got so many questions here. I just want to let everyone know I'm not going to be able to get through all of them. I'm just going to hit a few of the highlights. Several questions about partnerships with payers. Are you integrating claims information into your quality improvement efforts? What kind of payment structures, what's the market like in terms of payers who are supporting the work that you're doing? Do you have anything to report on that?
This is Karen. What I would say is that when we began this, we did it without having that support. So we like to think of it in terms of like if you're studying for an exam, you can either start studying for the exam 2 weeks before, get ready over a long period of time, or even 2 months before, and then you still get the A, or you can wait and pull an all-nighter and get the A. Well, we decided to start investing earlier, and so we did this without payer support, except the way that we tried to make sense of it was we tried to scope our work so that it would benefit us financially, so that we gave priority to our patients that are either our own employees, are either Medicaid, our Healthy York Network, which is our community charity care, or folks who are self-pay. So we asked our practices, which is totally outside of our norm, to think about those patients first. And the way that it made sense to them was we said, look, we don't have enough resources to take care of every single person that needs this care, so we have to cut the list somewhere. So let's start it with those 4 payer groups to begin with. And I would say that we're about 60% of the people that are in that one of those 4 groups, and the other 40% fall into areas where those payers have probably made off very well off our work.
Great. Yeah, it's still an ongoing challenge, and exciting that you had such commitment from leadership to really make that investment early on. So you've been so forward-thinking in terms of how you've been working with patients on your quality improvement. Can you talk a little bit more about how you're assessing not just patient satisfaction, but if you're also integrating in other patient experiences of care or quality of life, and around how you're doing some of that measurement?
I would not say we've done anything in terms of quality of life, and for patient experience, we're doing the typical CG caps and H caps, and then with our patient partners, Chris wants to say something.
This is Chris Amy from AFRQ. What I would say is that our patient partners have allowed us in our practices to look beyond CG caps or H caps and look at more what gets in the way of them getting good patient care, be that parking in a parking lot, doors that don't open properly, wheelchairs that are placed in the middle of waiting rooms, patient flows, it's safety concerns, it's convenience, not having the proper equipment in a room that staff have to run around. So it is the patient experience at a much broader level that we have reams of qualitative and anecdotal information of changes that practices have made so that patients feel much more tied to their practices. Example of a gentleman that absolutely was not happy about WellSpan taking over his practice, and by his involvement in patient partners has a total different viewpoint of healthcare. Many of these patients feel much more empowered in their care, and we see that their outcomes and their satisfaction improve.
Right. One thing we added to our patient shared care plan, and this was based on some literature search and some evidence, 3 questions. And one of the questions, now we haven't measured this yet, but it's our intent, and one of the questions is, compared to other persons your age, I feel my health is excellent, good, fair, or poor. And if excellent or good, what am I doing to stay at that level? These are 2 of the questions that we would like to get the patient's self-rated assessment of their health and see if there is a difference from the time that the care team engaged with the patient to the 6 to 12 month period. We just don't have the data yet on that, but that's what we would like to measure.
And probably the other piece to add to that in terms of our future plan and what we're working on for this upcoming year, we are integrating rehab services into, at least in our pilot practice, we have an initiative for assessing functional status in terms of get up and go assessments, and the rehab pilot in a practice is really, we're looking to that process and that pilot to help us articulate outcome differences in terms of quality of life as we move forward.
Well, that is all fantastic work that you're doing, and we're really excited to keep in contact with all of you and give everyone updates on the continuation of the great work that's happening in York County with all of your partnerships. We are past our time. I want to thank all of our presenters today and everyone who participated. There were many, many questions we could not get through, and so we're going to try our best to get a few of those answers for you and post them up on our website. We will have this archived, as we mentioned, up on our website by tomorrow. So feel free to share this link with other colleagues and partners that may have been out watching the World Cup soccer game instead of on the call today. But thanks again so much. Oh, go ahead.
Yeah, just so you know, the U.S. has advanced in the World Cup.
Oh, that's excellent news. Excellent news.
I have a husband who texts me.
I know everyone who's still on the line so appreciate that update. Thanks so much. Okay, we'll be in touch, and we'll talk to you all next month.
Thank you.
Thank
Bye.
you.
Bye-bye.